Robbie Williams lost over 25 pounds using weight loss injections. The results were dramatic. The scale dropped. The transformation was visible. And then he said something disturbing. He was struggling to recognize faces in the audience. One headline, two realities. These new GLP-1 injections are being called the biggest breakthrough in obesity treatment in decades. They lower blood sugar. They reduce cardiovascular risk. Some studies even suggest lower cancer mortality. But in the first 6 months, your body can change fast, and sometimes unpredictably. Rapid weight loss, shifts in medication absorption, rare but serious vision events, unexpected interactions with drugs you've taken for years. So the real question isn't whether these injections work. The real question is, what can happen in the first 6 months? And are you being monitored correctly? Tonight, we separate revolution from risk. Let's start by destroying a lie many still believe. Obesity is not simply a failure of willpower. Fat tissue is biologically active. It secretes hormones and inflammatory molecules that change how your brain senses fullness and how your body manages insulin. Over time, that chronic signal causes a disconnect, often called leptin resistance, where the brain stops hearing, "I'm full." People who have lived with excess weight are not lazy or weak. Their physiology has been altered in ways that resist dieting. Now imagine 2 ways of fixing that problem. The old approach, stimulants and appetite suppressants from the mid-20th century, was like swinging a hammer at the thermostat. Aggressive, blunt, often effective at first, and frequently breaking something important. That's the maretta, the hammer. The new approach with GLP-1 drugs tries to be more like fixing a broken thermostat. It nudges the gut-brain signaling that tells you to stop eating, restoring a set point rather than blasting the system. That metaphor helps explain why these drugs can produce dramatic weight loss while, in theory, being gentler on the heart or behavior. But the thermostat can still have wiring you didn't expect, and that wiring can cause surprises. We also need a quick visit to the medicine cemetery to remember why healthy skepticism matters. In the past, dinitriphenol caused fatal overheating and blindness. Amphetamines produced addiction and dangerous heart rhythms. Fen-phen brought valvular heart disease and pulmonary hypertension. Sibutramine and ephedra were associated with cardiovascular harm. Rimonabant delivered psychiatric harms. Those are not just old names. They are cautionary monuments showing how a drug that initially seems miraculous can later reveal severe, even lethal harms. The lesson is simple. Early dramatic benefit does not guarantee long-term safety. We celebrate progress, but we also watch carefully. So what is different about GLP-1 agonists such as semaglutide, marketed as Ozempic and Wegovy, and tirzepatide, Mounjaro? Mechanistically, these drugs mimic incretin hormones, molecules released by the gut after a meal that tell the pancreas to release insulin and tell the brain that you're satiated. They slow gastric emptying, reduce appetite, and improve insulin signaling. In plain terms, they help your brain hear the stop signal again, they blunt hunger pangs, and they improve blood sugar control. That's the thermostat repair, not the hammer. Technically, GLP-1 agonists act on receptors in the gut and brain, increase insulin secretion in a glucose-dependent way, suppress glucagon, slow gastric emptying, and reduce caloric intake. Slower gastric emptying is part of how they reduce appetite, but that same slowing is also the root of several safety concerns we must talk about. Let's balance the picture with the benefits reported in recent research, and then we'll move to risks you should not ignore, especially within the 6-month window that matters clinically. Multiple recent studies suggest real benefits beyond weight loss alone. For people with type 2 diabetes, randomized trials and real-world cohorts have shown improved glycemic control and reductions in some cardiovascular outcomes. A paper in JCC in 2025 reported heart-related benefits associated with GLP-1 therapy in certain populations, though the strength of that signal and which patients benefit most requires careful interpretation of trial design and follow-up time. Another striking analysis reported from UC San Diego in November 2025 noted a large association with lower colon cancer mortality in people using GLP-1s. As reported in the transcript, the study authors described a substantial reduction in colon cancer deaths among users, an eye-opening finding that is biologically plausible but observational in design, so we must interpret it cautiously. A JAMA Oncology report, OCT 2025, and other registry studies described reductions in incidence or mortality for some cancers. These signals have prompted enthusiasm and important follow-up research. Observational work has also linked GLP-1 use to fewer alcohol-related hospitalizations in some datasets, and improvements in fatty liver disease and sleep apnea have been observed in clinical trials and cohort studies. All of these are promising signals. They suggest that, in many people, these medications change metabolism and inflammation in ways that extend beyond the scale. But here is the crucial point. Many of these benefits accrue over weeks to months, and in parallel, some harms and interactions can appear within the first 6 months. That temporal overlap makes the 6-month period a particularly sensitive time for both monitoring benefits and watching for problems. What could happen in 6 months? Let's walk through likely scenarios, starting with the most common and moving toward the rare but serious. First, the expected, rapid weight loss and metabolic shifts. Within weeks to a few months, many patients experience meaningful reductions in appetite and body weight. Blood sugar often improves quickly, frequently allowing clinicians to reduce doses of diabetes medications, sometimes rapidly. Blood pressure and lipid profiles may also trend favorably. For someone with type 2 diabetes, those early months can look like a compelling victory. Second, common and usually manageable side effects. Gastrointestinal symptoms, nausea, vomiting, diarrhea, constipation, bloating, are frequent early on. These usually occur within days to weeks and often lessen with dose adjustments and time. For most patients, GI side effects are uncomfortable but self-limited if managed properly with a prescriber. Third, drug absorption and interaction problems that can be clinically important in the first months. Because GLP-1s slow gastric emptying, they can change how oral medications dissolve and are absorbed. For drugs with wide therapeutic windows, this is often unproblematic. But for narrow therapeutic index medications, notably certain anticonvulsants and anticoagulants like warfarin, small changes in absorption can translate to treatment failure or dangerous bleeding, clotting risks. Clinically, this can mean an epileptic patient experiences breakthrough seizures within weeks to months of starting a GLP-1 because their anticonvulsant levels dropped. Or an anticoagulated patient develops an unstable INR, or worse, thrombosis because of variable absorption. These are not hypothetical only. Registries and case reports have described similar scenarios. If you are taking medications where small blood level changes matter, the 6-month window is critical for monitoring and dose adjustment. Fourth, vision events. Reports have linked newer weight loss injections to rare but serious ocular ischemic events, including anterior ischemic optic neuropathy and other vision changes. Some case series and surveillance reports suggest a higher rate of early post-initiation events, weeks to months after starting therapy, in certain subgroups. The celebrity account that opened this conversation, the singer reporting difficulty recognizing faces, illustrates how devastating and life-altering vision loss can be, even if the event is rare. When a harm has a low absolute risk, but catastrophic personal consequences, even a tiny signal becomes clinically meaningful. Remember to ask your prescriber about baseline eye checks, especially if you already have glaucoma, diabetic eye disease, or recent vascular eye problems. Fifth, thrombotic and neuropathic signals. Some post-marketing data and surprised clinicians have reported thrombotic events and peripheral neuropathies after initiation. These are uncommon, but they can appear in the early months. It's tricky. Low absolute incidence multiplied by millions of users can translate to many affected people across a population. Sixth, changes in other chronic conditions. Rapid weight loss can unmask or improve conditions like sleep apnea and non-alcoholic fatty liver disease, often within months. Those are welcome changes and part of the therapeutic effect. But improvements may prompt medication dose reductions that, if not coordinated, can introduce instability. Conversely, rapid metabolic shifts may change how the immune system behaves or how cancer biology responds. That's why signals about cancer incidence and mortality require careful investigation rather than immediate celebration or alarm. Let me put this into concrete vignettes so the danger is not abstract. Imagine Anna, a 42-year-old woman with focal epilepsy controlled for 5 years on an anticonvulsant with a narrow therapeutic window. She starts a GLP-1 injection and loses 10 pounds in 8 weeks. 3 months in, she has 2 breakthrough seizures. Her anticonvulsant level, taken after symptoms, is significantly lower than before, a likely result of altered absorption. The seizure could have been prevented with earlier monitoring and a planned discussion about medication levels with her prescriber. Consider Mark, a man on warfarin for atrial fibrillation who begins a GLP-1. Initially, his INR is stable, but after dose titration of the GLP-1, his INR becomes erratic and then low. Several months later, he presents with a deep vein thrombosis. The interaction is complex and not always predictable, But the important point is that warfarin and similar drugs require closer surveillance when gastric motility changes. Then there is the high-profile anecdote. Robbie Williams reported rapid weight loss followed by severe vision problems. Anecdotes do not equal causation, but they are signals that deserve investigation. When individual stories are combined with formal surveillance data and case reports, they can form patterns that lead to new safety recommendations. How common are these problems? That's the heart of balanced risk communication. For many adverse events, the relative risk reported in a given study may look large, for example, a 2 to 4-fold increase, but the absolute risk may still be small. For instance, a rare event that occurs in 1 per 10,000 per year might become 2 to 4 per 10,000 per year. Conversely, a small relative increase of a common problem can translate into many affected people. The right way to interpret signals is to consider both relative and absolute risk, and to tailor the message to the individual's baseline risk. That is why shared decision-making with your clinician matters. Now a few words about the published studies you may have heard about, with the cautious framing they deserve. As reported in the transcript, a JAMA Oncology article, OCT 2025, and a UC San Diego analysis, NOV 2025, described impressive associations with lower cancer incidence or mortality in some cancers among GLP-1 users. In one reported dataset, a substantial reduction in colon cancer deaths was observed. A JAC 2025 piece and other cardiovascular cohort analyses reported favorable heart outcomes in some populations. At the same time, registry data and case reports published across 2025 and early 2026, and summarized in BMJ in January 2026, described weight regain after cessation and signals of adverse events. Each of these reports contributes a piece of the puzzle. Randomized controlled trials provide high-quality evidence for certain benefits like glycemic control and weight loss, while observational studies can reveal rare harms or potential benefits in outcomes not captured by trials. Always ask, was this a randomized trial or an observational cohort? What was the baseline risk of the population? Are the findings biologically plausible? These are the questions researchers and clinicians use to decide how much trust to place in a finding. So what is a responsible, practical path forward for patients and clinicians in the first 6 months after starting a GLP-1 weight loss injection? Here's a safety checklist you can use as a script for the clinic and for conversations at home. Before you start, if you take anticonvulsants, anticoagulants, including warfarin, immunosuppressants with narrow windows, or medications where blood levels matter, schedule a medication review with the prescriber and pharmacist. Ask specifically, could slowed gastric emptying change my drug levels? How will we monitor this? If you have pre-existing eye disease, recent vision changes, or vascular eye risk factors, see an ophthalmologist for a baseline exam and have a plan for rapid evaluation if new symptoms occur. If you are pregnant, planning pregnancy, or breastfeeding, discuss timing and alternatives. Many of these agents are not recommended during pregnancy. Review your cardiovascular history with your clinician. If you have heart failure or recent cardiac events, discuss which agent and dosing strategy is safest for you. During the first 6 months, expect the common GI side effects and plan a slow titration under clinician guidance to minimize them. Arrange early follow-up for patients on narrow therapeutic index drugs. Consider checking blood levels or INR within a few weeks of dose changes, not just at routine intervals. Watch for red flags that require immediate evaluation: sudden vision changes, blur, loss of peripheral vision, difficulty recognizing faces, new focal neurologic symptoms, sudden severe abdominal pain or persistent vomiting and dehydration, unexplained swelling or signs of clotting. Keep a symptom log of mood changes, sleep, appetite, and any new neurological or visual symptoms. Bring it to follow-up visits. If you experience breakthrough seizures or major INR fluctuation, contact your prescriber promptly. Do not wait for the next scheduled visit. For clinicians, educate patients clearly about the potential for altered absorption and the need for closer monitoring of drugs like anticonvulsants and warfarin. Communicate with the patient's other prescribers and pharmacists to coordinate monitoring plans. Consider baseline eye exams for patients with pre-existing ophthalmic risk and have a low threshold for ophthalmology referral if symptoms arise. Document the plan for dose changes of other medications in the chart and set reminders for early labs after therapy initiation or dose escalation. One more practical reality. For many patients, stopping GLP-1 therapy leads to weight regain. The BMJ analysis reported in January 2026 highlighted this pattern. Once the drug is discontinued, weight often returns over months, sometimes to previous baselines. That pattern suggests that obesity, like hypertension or diabetes, is a chronic condition for many people. Pharmacologic therapy may be a long-term tool rather than a short course with permanent cure. Framing dependence on a medicine as failure or addiction is unhelpful and stigmatizing. Instead, think of it as chronic disease management, the same way we accept daily medications for other long-term illnesses. So how should you weigh the benefits against the harms? Here are practical person-centered steps. 1. If you are considering therapy because of high baseline cardiometabolic risk or uncontrolled diabetes, the potential benefits may be substantial, and a discussion with a clinician may lean toward starting treatment with close monitoring. 2. If you are on critical narrow therapeutic index medications, the decision requires more caution and planning. It does not mean you cannot use the drug, but it does mean you should not start it without a coordinated monitoring strategy. 3. If you have a strong family history of certain cancers or existing liver disease, discuss with your clinician how the current evidence applies to you specifically. Observational signals about cancer mortality are intriguing but not definitive. They require further study before we claim prevention. 4. If you experience alarming symptoms, any sudden vision change, new neurologic deficit, unexplained bleeding or clotting, or severe dehydration from GI loss, seek immediate medical attention and inform your prescriber that you are on a GLP-1 medication. Let me be clear on what I am not saying. I am not telling you to avoid these drugs categorically. I am not promising that they will prevent cancer or cure diabetes for everyone. The correct posture is balanced. These medicines are powerful tools with meaningful benefits for many patients, but they are not risk-free, and early vigilance, especially in the first 6 months, is essential. To close, here is a concise checklist you can take to your next medical visit. Read it aloud if it helps. Tell your clinician every medication you take, including over-the-counter drugs, supplements, and herbal products. Ask, could this new medication change how my other medications are absorbed? Should we check blood levels or INR sooner than usual? Ask, do I need a baseline eye exam? What symptoms should prompt immediate evaluation? If you are on anticonvulsants or anticoagulants, ask for a written monitoring plan and a timeline for labs after starting or titrating the GLP-1. Agree on follow-up timing within the first 6 weeks and again at 3 months, with a plan to reassess at 6 months. If you become pregnant or plan pregnancy, stop and seek specialist advice before continuing. Medicine advances quickly. The early results with GLP-1 agonists have been transformative for countless patients. But history teaches that early promise must be matched with ongoing surveillance. In 6 months, you may celebrate real improvements. Lower A1C, less snoring, smaller clothes, feeling stronger. But you may also need to address unexpected changes, a new lab result, altered medication levels, or a troubling symptom. That 6-month window is where vigilance makes the difference between a success story and a preventable complication. If this video spoke to you, or if you know someone thinking about these injections, please share it with your clinician. That single conversation could change monitoring and prevent harm. Stay informed, ask the right questions, and remember, medicine is not binary. These are powerful tools when used thoughtfully, monitored carefully, and combined with the rest of a comprehensive health plan. If you want more in-depth breakdowns of the studies I mentioned, the JAMA Oncology piece, OAKT 2025, the UC San Diego Report, NOV 2025, the JACC 2025 analyses, and the BMJ Review, Jan 2026, and practical guides for the clinic, subscribe and watch the playlists linked next. I'll continue to walk through the evidence, the mechanisms, and the practical steps you can take to keep you and your loved ones safe while benefiting from medical advances.